Hello, guys. A very good evening to all of you. And I know that Hello, guys. A very good evening to all of you. And I know that the match is going on, and mostly India is gonna win the match. I know that. So I also wanted to watch it, but anyways, work is work. And you see, I don't want to be complacent. I could have shifted it half an hour or 1 hour, but you have to learn that what comes first. What is your first priority? आपका पहली प्रायोरिटी क्या होना चाहिए, right? So you cannot compromise on that. Later on, we can see how much balls, how much runs, and etc. Anyways, the fireworks of Surya Kumar Yadav you all have seen, right? So guys, first of all, tell me how are you all? कैसे हो आप सब? No, it's okay. I'm not gonna watch it because see, India will win anyways. Now it's just a formality. So how are you guys? कैसे हो आप सब? Amazing, 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 guys. All right. So we'll begin today's session. Says is third session, weekly pharmacology, and if now see if you want to watch the cricket, you can watch it, and you can watch the session later because you see I'm not deleting these sessions. These sessions are pretty much there until your exam, and this is our next target CNS for next week, central nervous system. Monday, Tuesday, Wednesday, Thursday, Friday, Saturday. These are the topics you have to cover, and you can take a picture of this. So, anyways, I'm gonna post it right tomorrow or today. It's all I'll post it on Instagram and Facebook everywhere. There is one catch. There is a live session on Sunday, but Sunday I'm not in Delhi. I'm not in Delhi. Yeah, on Sunday, I will be in Odisha because I'm from Odisha, and Dashera is an important festival in Odisha. So those 1 week of Dashera, in around Dashera, I have to be in my house. That is, my obligation towards my parents and my family members. So, but anyways, it does not mean we're not gonna do anything. Next Sunday, it will not be a live session next Sunday, but it will be a premiere. Right, it will be a premiere. That premiere means what? Before I leave for Odisha, I'll record the session, and it will be posted on Sunday, and I will be in the chat box. I'll be in the chat box. So I cannot do a live session from Odisha because I don't have a studio over there. But obviously, I have a mobile phone, so I can chat with you guys. So as it is, I've said the most important part is not the Sunday one. The most important part is from Monday to Saturday, whatever we do from Monday to Saturday. So our aim here is, so I hope you guys are doing it. Read, revise, then re-revise. Are you guys following this? Read, revise for 15 minutes, re-revise for 5 minutes. All right. So let us begin with today's session, guys. A patient presented to emergency with atrial fibrillation. Started on a drug that made arterial rate of 220 beats per minute. See, with an arterial rate of 220 beats per minute and a ventricular rate of 180 beats per minute, he was started on a drug that made the arterial rate 220. So it was 220, it is still 220, and the ventricular rate 120. But see, there is a change in ventricular rate. It was 180, now it is 120. Which of the following drug doctor might have started in the patient? Right, doctor might have started in this patient. It's a very simple question. If it's a very simple question, if you apply the logic, right, you have to think and you have to apply the logic, and you can easily find the answer. You can easily find the answer. So see, whenever you'll ask the question, suppose this is the heart, this is the heart, and suppose there is an area that is causing atrial fibrillation. And atrial fibrillation, the atrial rate is 220 beats per minute, and this is also coming down to the ventricles, the ventricular rate. So the conduction system, it is coming down. Suppose this is your ventricular rate was 180 beats per minute. Now I've given a drug which has decreased the ventricular rate, but the atrial rate, there is no change. The atrial rate has not changed. Right, so what is the answer here? Adenosine, verapamil. Come on, guys, think. Whatever is the answer, whatever you know, whatever you can think of, comment. Because see, here there is nothing to feel ashamed of, right? We are not giving marks here. We are not giving seats here. So you should comment the answer. It's an easy question, guys. I've taught you how to think about treatment of arrhythmia. I've taught you how to think about treatment of arrhythmia. You have to think, what is my target for treatment? Is my target AV node? That means, do I have to block AV node, or do I have to block the myocardial tissue? Isn't it? So I've taught you this. You have to be rational. Don't just blindly go for any answer. Apply your brains, look at an MCQ and think, what is it that you are aiming for? Targeting AV node or myocardial tissue? Now think here. Atrial rate. I give a drug. Atrial rate does not change, but ventricular rate changes. So what have I blocked? Myocardial tissue or AV node? Maurice Columbus, CVS is tough. The only thing is that you have. So what have I targeted? Myocardial tissue or AV node? First of all, give me this answer. In this case, if I give a drug, atrial rate does not change, but only ventricular rate changes. What have I blocked? AV node? Have I blocked AV node, or have I blocked myocardial tissue? What have I blocked? AV node or myocardial tissue? Now, whoever is giving an answer as myocardial tissue, think again. If I block myocardial tissue, won't it block the myocardial tissue both in atrium and ventricle? Isn't it? In that way, if I block myocardial tissue, it should decrease both atrial and ventricular rate. That means I'm not blocking the myocardial tissue. I blocked what? AV node. So if I block the AV node, the action potential remains in the atrium. It does not come to the ventricle. And this is something called as, in atrial fibrillation, this is something called as rate control. So many of you have said this in the chat box, that AV node. So I blocked AV node. So in other words, look at this MCQ. I'm asking, which of the following can be used for rate control in atrial fibrillation? So this MCQ boils down to this 3 or 4 words. Drug that is used for rate control in atrial fibrillation. Is it A, B, C or D? Now can you at least give me the answer now? क्या आप अभी आंसर बता सकते हैं कि एट्रियल फिब्रिलेशन में रेट कंट्रोल के लिए इनमें से कौन सा यूज होता है? इज इट ए, बी, सी और डी? अरे बीटा ब्लॉकर तो नहीं है ना दादा आंसर में, ऑप्शन में देयर इज नो बीटा ब्लॉकर इन द ऑप्शंस. There is no beta blocker. So I've told you how to remember the AV nodal blockers. I've told you how to remember the AV nodal blockers: A, B, C, D. Adenosine, beta blocker, calcium channel blocker, verapamil, digoxin. But adenosine cannot be the answer here, because adenosine is contraindicated in atrial fibrillation, because adenosine itself causes atrial fibrillation. So your answer is verapamil. Right? So see, beta blockers are the drug of choice, but if beta blockers are not in the option, I can go for verapamil. If verapamil was not in the option, you could have gone for digoxin. So it's a simple MCQ, guys. It's a simple MCQ. Next is a clinical case. The second one is a clinical case I've given you so that you can analyze. A patient of depression was brought to the emergency with 1 episode of seizure. Patient is suffering from depression and consumed 20 pills of antidepressant which he was taking. His blood pressure was 120/80, heart rate was 180, ECG was advised and ventricular arrhythmia was confirmed. Which of the following antiarrhythmic drugs should not be used in this patient? Which antiarrhythmic drug should not be used in this patient? Amiodarone, lidocaine, flecainide, propranolol. Now, it's a difficult question. It's a clinical question, but still, I want you guys to at least attempt and at least find out what could be the possible answer. Then I'll tell you the logic behind it. All right, so first of all, you have to understand the antidepressant. All right, tell me, which antidepressant is this? Which antidepressant is this? Which antidepressant is this which has caused ventricular arrhythmia? Tell me the antidepressant. Which antidepressant is this? Is it MAO inhibitor, SSRI, tricyclic, SNRI, metazapine? What it is? Now this, to be specific, this is an antidepressant called as TCA, tricyclic antidepressant. And see, tricyclic antidepressants, they have quinidine-like effect on the heart. And that is QT prolongation. Tricyclic antidepressant, they can cause QT prolongation and they can cause torsades. They can cause torsades. Right, they can cause torsades. So now tell me. Now I've given you some clue now. Earlier the question was difficult, but since I've given you the clue, the question is not that difficult now. Right? Now can you at least tell me the answer? Which one is the answer now? A, B, C, or D? Now the answer is pretty much obvious. What is the answer? Is it amiodarone, lidocaine, flecainide, propranolol? Now guys, come on, think now. What is the answer? Is it A, B, C, or D? अभी जो आंसर है वो प्रत्यक्ष है, मैंने बता दिया आपको. Answer is now obvious. In other words, I'll not use another antiarrhythmic drug that causes QT prolongation. And answer is, most of you are giving the right answer, amiodarone. So I've told you, in antiarrhythmic, two drugs are important in antiarrhythmic drugs causing QT prolongation. These are class 1A and class 3. And side effects of amiodarone are important. Amiodarone side effects are important. So here answer is amiodarone. So I'm just, and for this, if they would have asked you, what is the drug of choice? Then your answer would have been sodium bicarbonate. Now this MCQ was asked recently. If they would have asked you what is the drug of choice for this condition or what is the drug of choice for this arrhythmia, your answer is sodium bicarbonate. A patient on amiodarone develops corneal deposits, but his vision is normal. What is the next best step? So, nowadays I ask you 5 to 6 questions every day. I give you every day's topic. I will ask you every day 5 to 6 questions on Instagram. And this is one question that I asked on Instagram. And majority of you, they have answered it wrong. But let us see what happens today. Change the drug, decrease the dose, continue at same doses, add steroid eye drops. So what is the answer, guys? Come on. What is the answer? Change drug, decrease dose, continue at same doses, add steroid eye drops. Now see, remember, here the answer is continue at same doses. The reason being, if corneal deposits are there, and then you have to look at vision. If vision is normal, then CST means continue same treatment. Right? If vision becomes abnormal, then you can think of changing the drug. Second thing, they can ask you, what about these corneal deposits? Are they reversible or irreversible? Your answer would be they are reversible. So once I stop the drug, so why I will change the drug? While change the drug, if vision becomes abnormal, once I change the drug, it is reversible, then vision will automatically improve. That is the reason why, right? It's reversible. So continue at same doses. So amiodarone side effects are important. So that is the reason why I've asked you this question. They can ask you, which of the following drugs is used in heart failure but has no direct effect on the heart? Even this MCQ I had asked you on Instagram as well. Change to which drug? Sagala Charan is asking, change to which drug? Change to a drug which is appropriate for that condition. So if I'm dealing with an arrhythmia with ventricular tachycardia or atrial fibrillation, I can change to another potassium channel blocker. Like I can go for dofetilide, right? Which of the following drug is used in heart failure but has no direct effect on the heart? Dobutamine, carvedilol, captopril, digoxin. This is another MCU that I had asked on Instagram as well. Dobutamine, carvedilol, captopril, digoxin. It's an easy one, guys, and I'm really happy that most of you have given the right answer here. Come on. So what is the answer? A, B, C, or D? C is the right answer. And captopril, as all of you know, captopril, it is used in chronic CHF, but its effect is not direct on the heart. It is indirectly, that is via RAS. And you know, RAS is responsible for cardiac remodeling, hypertrophy. That is what is blocked by captopril, and that is the right answer. Excellent, guys, excellent. The first drug a patient of chronic CHF is always started upon: ACE inhibitor, beta blocker, furosemide, vericiguat. Alright, so what is the answer? A, B, C, or D, guys? The first drug a patient of chronic CHF is always started on: ACE inhibitor, beta blocker, furosemide, vericiguat. Alright, all of you have given this answer right according to the older guidelines. But as I've said, these live sessions are not only to practice MCQs, but to give you some updates, some changes, something new. Now remember, whenever a patient of chronic CHF comes to us, the first drug, according to the recent guidelines, we are going to start is furosemide. Furosemide, but remember, furosemide is started for volume overload. It is started for volume overload. So make this change in your notes, right? For volume overload, I have to start the patient on furosemide. Then to decrease mortality, then I'll be starting ACE inhibitors or ARBs, etc. So this is one slight change in the guidelines for treatment of chronic CHF, which is there. And so just add this line that before starting ACE inhibitor ARB to decrease mortality, to decrease volume overload, to make the patient asymptomatic, the first drug that is started is furosemide. Second is beta blocker. See, everything else is same that I've taught you. Everything else is same. I'm going to use ACE inhibitor, ARB, sacubitril, valsartan, beta blocker, right? Second drug that I'm going to start here is beta blocker. So every patient is on 3 drugs. Every patient of chronic CHF is on 3 drugs, and these are furosemide, ACE inhibitor ARB, beta blocker, or nowadays sacubitril valsartan is also a good option. Beta blockers are used. Beta blockers are also used. All right. So here your answer is furosemide. Please make this change in your notes. If they ask MCQ, if you'll mark ACE inhibitors now, the answer will be wrong. All are contraindications of digoxin. Now guys, remember, digoxin is a very, very important drug. So digoxin, see, in case of cardiovascular system, in your 20th notebook or before the exam, you have to remember drugs causing QT prolongation. You have to remember side effects of and contraindication of amiodarone, digoxin, and ACE inhibitors. So you look at PYQs, you look at previous year's question, you will understand that even if you do this much, then most of your job is done. Hypocalcemia, hypomagnesemia, hypokalemia, HOCM. I've told you earlier, you will have in NEETPG, you'll have such type of MCQs which are easy, and you should not spend more than 5 seconds to go for the answer, which is hypocalcemia, because those 55 seconds which I'm gonna save here, I'll use it for questions which are difficult to solve. So it is not hypocalcemia, rather it is hypercalcemia. Hypercalcemia, it is a contraindication for digoxin because hypercalcemia increases risk of digoxin toxicity. Right, so it's a simple one, guys. HOCM is not the answer, guys. HOCM is a contraindication. All are used in digoxin toxicity treatment except potassium, atropine, digibine, dialysis. Again, so I've given you quite a few number of questions here, right? Signifying that digoxin is an important drug. There is a reason why I've included a good number of questions from digoxin. Right, so all are used in digoxin toxicity treatment except potassium, atropine, digibind dialysis. It's an easy one. You can solve it. You can solve it even from the knowledge of G Pharma. G Pharma, we had read in G Pharma about volume of distribution, and it is something related to volume of distribution, isn't it? Come on, guys. Let's answer flow. Come on. What is the answer? Now, if someone thinks potassium is the answer, if potassium is not the right answer, yes, the answer is dialysis. See, dialysis can never be done for digoxin because digoxin has a high volume of distribution, right? So we cannot do dialysis. It's a simple MCQ. Now, potassium is not the answer. Potassium is used, right? Potassium is used in case of benign arrhythmia. If there are benign arrhythmia like ventricular premature beats or extrasystole or ventricular bigeminy, I can use it. But remember, if the patient develops ventricular tachycardia or ventricular fibrillation, do not use potassium because ventricular tachycardia or fibrillation signifies higher level of digoxin toxicity, severe digoxin toxicity where potassium is already high. If I give potassium, that could be detrimental. Atropine, all of you know, atropine can be used for treatment of AB block. Digibind is the antidote, is commonly asked. So excellent, guys. Your answer is dialysis. D for dialysis is the right answer. For TDM, the plasma level of digoxin should be checked after how many hours of oral administration? Now, this MCQ has been asked for lithium. In our exams, lithium has been asked, where the answer is after 12 hours. Right? These are two important drugs where I do TDM. Lithium, they have asked. Digoxin has never been asked. Digoxin has never been asked. That is the reason why I have made this MCQ. See, lithium is 12 hours. Lithium is 12 hours. But looking at lithium, if you go for 12 hours, this MCQ will become wrong. Digoxin, some of you have given the right answer. Digoxin, it is 6 hours, guys. TDM is done for digoxin after 6 hours. So answer here is B, 6 hours. Right. So you should remember these 2 points. See, these points are highly scoring, and at the same time, they're difficult bunch because you cannot apply any logic here. Either you know the answer or you don't know the answer. Now, many students, what they will do, because last time lithium, the answer was 12, they'll go for 12, but 12 is not the right answer, 6 hours. 6 hours. If I'm using it by oral route, if I'm using it by IV route, 4 hours. But remember, IV route is not used nowadays. We use oral. So if nothing is mentioned, then you still go for 6 hours because we use oral route. Why 6 hours? Because see, if I'll measure earlier, if I give digoxin, it has high volume of distribution. It has high volume of distribution. So if I measure before 6 hours, it could be falsely elevated. Right, so it will take 6 hours for the drug to get distributed and achieve a plasma concentration. For that is the reason. No, here there is nothing related to half-life. There is nothing related to half-life. Time taken for digitalization is 2 to 3 days, 3 to 4 days, 5 to 6 days, 7 to 10 days. Lost boy, no, we don't wait here for the first measurement because the first measurement, it will take a lot of time, right? And that is the MCQ that I'm discussing now here. I'll tell you in a short while. Time taken for digitalization. Now, excellent, guys. What is the answer? 2 to 3 days, 3 to 4 days, 5 to 6 days, 7 to 10 days. See, digitalization means what? It means to achieve steady state concentration for digoxin is called as digitalization, and steady state concentration requires 4 to 5 half-lives. 4 to 5 half-lives, and that is the reason why here, see, the half-life is 36 to 48 hours digoxin. So if you look at this, the answer that we get is 7 to 10 days, and I've covered this in the lecture. Excellent, guys. This is something it has been asked. Many years back in NEETPG, they had asked you 7 to 10 days. So see, to draw the initial plasma concentration, now you have to understand this is what I'm asking is whenever I do TDM, I'll do it after 7 to 10 days, after I achieve steady state concentration. But after how many hours of drug? These are two different things. After how many hours of drug? So TDM will be done after 7 to 10 days, but after 6 hours of drug. After 6 hours of drug. See, what I'm saying here is lithium has a half-life. Lithium has a half-life of 24 hours. So TDM is done after 5 days. That is one thing. But when you take the drug, when you take the blood, I mean to say blood, after 12 hours, you got my point? So these are two different things. So someone had asked this doubt. तो आपने डाउट पूछा था कि 7 से 10 दिन के बाद स्टेडी स्टेट आएगा, right? Steady state will come after 7 to 10 days. How can I take it after 6 hours? See, I'm taking it after 7 to 10 days. But here the MCQ is after how many hours of taking digoxin? After 7 to 10 days, after 6 hours of taking the tablet, right? A patient of bronchial asthma presented to emergency with tearing pain in the back, which is unbearable. He was immediately started on morphine for pain. His blood pressure was 180 by 120. After investigation, he was diagnosed as a case of aortic dissection and started on. Look at the options carefully. Take some time to get these options right into your brain. Labetalol plus phentolamine, esmolol plus nitroprusside, verapamil plus nitroprusside, esmolol plus phentolamine. Right. So it's not a difficult MCQ. It's an easy one. But again, such type of MCQs, they will separate the rankers from non-rankers because it's not an easy, it's not a difficult, it's a moderate one. And such MCQs, they'll separate the rankers from non-rankers. A, B, C, or D. What is the answer, guys? So it's a case of aortic dissection. And aortic dissection, the drug of choice, is beta blockers, isn't it? Drug of choice is beta blockers. But we have a patient of asthma. So can I give beta blockers? So once patient of asthma is there, beta blockers are out. So beta blockers is drug of choice. So if I cannot give beta blockers, then what I give CCB like verapamil. Right? In place of beta blocker, I can use. If beta blockers cannot be used in aortic dissection, then I go for beta blocker. Remember, phentolamine is not used, but nitroprusside is used. Right? So you can use either verapamil or nitroprusside. If I add nitroprusside, it helps by decreasing preload on the heart. Right? So answer is C, guys. Excellent. I'm proud of all of you. Most of you have given the right answer. Drug of choice for hypertension, treatment of hypertension with CKD with edema. Drug of choice for treatment of hypertension with CKD, chronic kidney disease with edema. Captopril, nifedipine, metolazone, spironolactone. Lost boy, we can use selective beta blocker. No, selective beta blocker are not absolutely selective. I told you this in the lecture. Selectivity in pharma is never absolute. So even selective beta blockers, they block beta 2, right? So if I have an option, I'll run away from beta blocker in asthma, right? Is it A, B, C, or D? Come on, guys. Come on, answer. I know this is a little bit, with a twist. What's the answer here? Come on, guys. Come on. What is the answer? A, B, C, or D? What is the answer? A, B, C, or D? Right, देखो. Now, many of you have gone for captopril as the answer because you have focused on hypertension with CKD, but you have missed out on edema. Now remember, hypertension with CKD, if edema was not in the option, I would have gone for captopril as the answer, because there is edema. Captopril will not be the answer. The answer would be metolazone. See, so hypertension with CKD, if they ask, there is proteinuria, for example, but there is no edema, I'll happily go for captopril. But if there is edema, I'll go for a thiazide. So remember, hypertension with CKD, edema is not mentioned. Please go with captopril. That is the right answer. But if edema is mentioned, please go for a thiazide as an answer. Metolazone will be the answer here. Right? Captopril. Yeah, captopril will. No, see, it's not about affecting kidney. Captopril is not going to help us in edema. Captopril will not help us in edema. Are you getting my point? All right. I've given another clinical question. A patient is on isosorbate dinitrate and diltiazem for treatment of chronic stable angina for last 2 years. He was asymptomatic during entire period. He was on drugs. One day he received WhatsApp forward message which said how allopathic medicines are toxic and are made only for profiteering. So he stopped both drugs, started taking some herbs after consultation with someone selling herbal drugs in a tent. After 1 week, he developed severe chest pain and was taken to emergency. The development of chest pain in the patient is because of enzyme induction by herbal medication, progression of angina, increased preload on the heart, increased heart rate. Now see, this MCQ that I made is related to the real life. Nowadays, these things they happen. The people, they do come up with miraculous, treatment things, and it's very easy. So see, we doctors, we are the soft punching bags nowadays, because every patient they will cross check you, and पहले से ही पेशेंट दिमाग में एक बात लेकर के आता है कि ये डॉक्टर मेरे से पैसा कमाना चाहता है, राइट? So these things they happen. They happen in my family. Forget about other people, because it is very difficult to make people understand that you cannot cure diabetes. Now, my mother gets a WhatsApp forward a video that by chewing some leaves, diabetes goes away. So it's very difficult to make my mother understand कि diabetes है, भूत नहीं है कि चला जाएगा. Diabetes कहीं नहीं जा रहा. It's not going to go anywhere, right? So guys, what is the answer? All of you have given the right answer here. Answer is C, increase in preload on the heart. Increased preload on the heart, because you see, this is a patient of chronic stable angina, and in stable angina, the main mechanism of action is that of isosorbate dinitrate. It is due to decreased preload. Preload, it decreases the myocardial oxygen demand, right? So that is the mechanism of action. And this I've asked this MCQ indirectly related to mechanism of action. So answer is C, guys. Excellent. Most of you have given the right answer, and I'm really happy. Not a correct match for mechanism of action. See, mechanism of action is a commonly asked in angina. In angina, in your 20th notebook, you don't need to write anything. Just write the mechanism of action of all drugs. That's what they ask 90% of times. Ranolazine beta blocker, ivabradine PFOX inhibitor, fasodil Rho kinase inhibitor, nicorandil potassium channel blocker. What is the answer? Oof. Actually, I made this MCQ wrong. Ivabradine. Alright, I'll change this MCQ. Ivabradine. Funny channel inhibitor. Guys, so I'm really sorry. I made this MCQ wrong. Funny channel inhibitor. Ivabradine, funny channel inhibitor, fasodil Rho kinase inhibitor, nicorandil potassium channel blocker. Because if ivabradine is PFOX inhibitor as an option, then there is no answer. then there is no answer, right? So these are the new options: ranolazine beta blocker, ivabradine, funny channel inhibitor, fasodil Rho kinase inhibitor, nicorandil potassium channel blocker. Now what is the answer? Ranolazine beta blocker, ivabradine funny channel blocker, fasodil Rho kinase inhibitor, nicorandil potassium channel blocker. Now what is the answer? See, A, B cannot, A, there is only, see, ivabradine, as I've said, ivabradine, I made it wrong. So what is the answer here? India wins. So, see, I knew it. Yeah, I never wanted B to be the wrong answer actually. See, here the answer is nicorandil, because nicorandil, it is a potassium channel opener. But remember, ranolazine is a beta blocker. It's a beta blocker, but its main mechanism of action is block of sodium channels. The primary mechanism of action is sodium channel block. Secondary mechanism of action is beta block. Ranolazine, right? Ranolazine can also block beta blocker. Ranolazine can also block PFOX, or partial fatty acid oxidase. So ranolazine has three mechanisms. But if they ask you which is the best answer, single mechanism, sodium channel blocker. Right, secondary mechanisms, these are PFOX inhibition or partial fatty acid oxidase, beta blocker. Ivabradine is a funny channel blocker, fasodil Rho kinase inhibitor. Nicorandil, it is a potassium channel opener, not a blocker. It is a potassium channel opener. So here, your answer is D. So anyways, I wanted to make an MCQ on the mechanism of action. So angina, whenever you revise, forget about everything. Just see if you remember all the mechanism of action or not. A patient recently diagnosed with stable angina was to be started on appropriate hypolipidemic drug. He is a patient of chronic constipation and is taking prebiotics for the same. Which of the following hypolipidemic drugs should not be started in the patient? Cholestyramine, rosuvastatin, estimab, and niacin. क्या नहीं देंगे? See, why constipation is bad in stable angina? Rho kinase glaucoma में भी यूज होता है. Rho kinase is used in glaucoma as well. So guys, which one should not be used? Cholestyramine, rosuvastatin, estimab, or niacin? Excellent. See, in the previous question, option A is right because ranolazine is a beta blocker also. Right? Faizan Ahmad, ranolazine is a beta blocker also. That is why it is right. Alright guys, so constipation, see, you have to understand constipation is not good. It's not good for angina because whenever the patient sits on the pot and keeps singing आती नहीं, तो बहुत देर तक जब पेशेंट गाना गाएगा आती नहीं, तो हार्ट रेट क्या होगा? हार्ट रेट इंक्रीजेस because of exertion heart rate increases. That is bad for angina. So here answer is cholestyramine, because cholestyramine, it causes constipation. Cholestyramine, it causes constipation. And if at all I want to use a bile acid binding resin, then I should go for cholecyvalum because it has lesser effect on GIT. It has lesser effect on GIT, right? So answer is cholestyramine, guys. True regarding statins. Which of the following is true regarding statins? Monitor LFT, monitor CPK, monitor blood glucose. None is true. What is the answer? True regarding statins. Statins is very important class of drug. Statins are frequently asked in your exam. Hypolipidemics में सबसे important class है statins. सबसे important. Statins are most important. Monitor LFT, monitor CPK, monitor blood glucose. None is true. All right. Again, guys, the reason I have made this MCQ, it is to give you one more update. Uh, that is, and I've updated this in the recent edition in Marrow as well. Remember, earlier we used to monitor LFT, but it is wrong now. We do not monitor. Even we don't monitor LFT. CPK, we never used to monitor. Blood glucose, we don't monitor. So answer here is none is true, or none of the above. Never underestimate the power of none of the above or all of the above. They are very powerful options, right? So we do not monitor LFT. Now this is the recent change, guys. If you have followed me in the edition 5 of Marrow, then change it in your notes. Edition 6, I've updated it. Edition 5. So LFT is not to be monitored. The reason being, it has been seen in the recent clinical trials. Even if I regularly follow LFT, still I'm not able to prevent hepatotoxicity. So there is no fun in giving physical and financial burden to the patient, right? CPK is not monitored because myopathy is delayed. This is something which I've taught for many years, right? CPK भी नहीं करते. CPK भी नहीं करते. See, Marrow, there is no individual lecture subscription. Marrow is a platform where they give the bunch of 19 subjects. Monitor blood glucose. It causes hyperglycemia, but we don't monitor blood glucose, right? Myopathy is a delayed. So here, guys, none is true is the right answer. Which of the following is a stimulator of PPAR alpha? Now, this is an MCQ I'd asked on Instagram as well. Instagram, I had asked, 90% gave the wrong answer. So I've given you a clue. 90% gave the wrong answer. Oh, but here almost 100% are giving the right answer. Right, which of the following is a stimulator of PPR alpha? Guys, here, when I posted on Instagram, most of the people, they went with bezafibrate. Is not the right answer here. But bezafibrate is not a stupid answer, right? You know, so there are some stupid answers. It's not a stupid answer. It's a good answer, but it is a wrong answer. Good answers can be wrong answer, because here it's not about good answer. It is about the best answer, and the best answer here is D. The reason being, remember, pioglitazone is a stimulator of PPAR gamma, plus it also stimulates PPAR alpha as well, right? It also stimulates PPR gamma and alpha. So here D is the right answer. Both B and C are correct. So D is the right answer, guys. D is the right answer. Alright, guys. So now you can ask your doubts, and whatever doubts, if you have any doubts related to cardiovascular system, then we are ready to go ahead with your doubts. If not, you can go ahead and revise. So guys, I'll remind you again, whatever we are doing, it is not gonna work. देखो, जो भी हम कर रहे हैं, in 1 week, I'm dividing it from Monday to Saturday, right? And every day I'm asking you to read 1 to 2 hours only. This thing is not gonna work if you're not gonna do this 1 to 2 hours, 15 minutes and 5 minutes. अगर आप ये नहीं करेंगे, if you're not doing this, then there is no purpose. This is not gonna help you, right? But by doing this, what will happen is, you will realize when you go to revision how solid you are in pharma. This is not only pharma. You do this with any subject, micro, medicine, whatever subject you're weak in, and that would become your strongest subject, right? MCQ discussion videos of Marrow be released. See, we have already recorded, so it's on the way. And the exam is on March, so you can relax. All right, Kaushik Das, what will be the least common side effect of captopril. See, angioedema. Angioedema is the least common side effect of ACE inhibitors. Now tell me, you would have never seen angioedema in your lifetime with a patient on ACE inhibitors because it's rare. Like angioedema is a life-threatening side effect. It can cause laryngeal edema. Patient can die. If angioedema would have been that a common side effect, we, in the first place, would not be using ACE inhibitor, right? See, CPK monitor nahi karte. If you are doing CPK before starting a drug, that is not called as monitoring. You have to do LFT also before starting statins, right? But that does not mean monitoring. Monitoring का मतलब क्या होता है? What do you mean by monitoring? That whenever I'm giving the drug, every 1 month or every 3 months or 6 months, I'll continuously do until for as long as he's on the drug. Atypical medico, 5 minutes on third day, sir. What is 5 minutes on third day? I don't like. I'm not able to understand. What does it mean? How IVIG is drug of choice in GBS, Guillain-Barré syndrome. See, Guillain-Barré syndrome, GBS is basically autoimmune. You know what is GBS? Autoimmune. And remember, antibodies can target antibodies. So one antibody can neutralize a second antibody. That is the reason how we use it in GBS. रोशन राज, CHF, क्रॉनिक CHF का जो फ्लो चार्ट है वो करेक्ट है. फ्लो चार्ट इज करेक्ट. See, captopril test, we give captopril, captopril increases renin, right? There can be renovascular hypertension, there can be essential hypertension. If renin increases significantly, it is renovascular hypertension. If there is non-significant increase, it is essential hypertension, right? So this is your captopril test to diagnose renovascular hypertension. Rishabh Shukla, see, there is no way currently to access my lecture via website because I have stopped it. Praniti Simlot, how to make 20th notebook. See, there is something, you can go in Marrow and there is something called a schema. And as far as pharma is concerned, I've given a list of things that you need to do or revise before the exam, just before the exam. As medico, if there is hepatotoxicity, we stop the drug. Amiodarone can cause torsades, but the risk is lesser. High blood pressure, patient develops encephalopathy, not use furosemide, indapamide, nitroglycerin, clevidipine. Now see, Kaushik Das, here answer is indapamide. The reason being it is a case of high blood pressure, encephalopathy. It's a case of hypertensive emergency. Emergency, we use IV drugs. I'm not going to use indapamide. It's not an IV drug. Rho kinase inhibitor that is given in glaucoma, it is netar-sudil. Netar. So you can remember from netar, what is eye called as in Hindi? Netra. Netra is eye. So netar-sudil is used in glaucoma. See, ankle edema is bothersome for the patient. You imagine yourself, your ankle is always edematous. So that bothers the patient, right? That is the reason why you have to change the dose, combine ACE inhibitor or change to any other drug. Bipasha Datta Roy. So why arrhythmia post-MI is caused due to calcium influx and why we use lidocaine? See, MI is caused with calcium influx. Why we use lidocaine? Because see, I've explained this. If you've gone through my marrow lectures, I've explained this, is when calcium increases in MI, then what this does, this calcium generates action potential, depolarizes the cell, and because cells are depolarized, the sodium channels, they go into closed state. They go into closed state. They're in closed state. And that is the reason why I use lidocaine, because lidocaine, it blocks sodium channels in closed state so that the action potential cannot be propagated further whenever these sodium channels open. Others are not effective. Hypomagnesemia increases digoxin toxicity. The reason being calcium and magnesium. You see, the relation of calcium and magnesium is opposite. Whatever happens in hypercalcemia happens in hypomagnesemia. The reason is magnesium blocks calcium channels. This is something we study in physiology. Magnesium blocks calcium channels. Netra, yeah, Netra is an ODI as well, right? See, what I'll be discussing next week, I think you guys missed up on that. What I'll be discussing next week, I mentioned in the beginning. I'll be discussing CNS, Central Nervous System. Yeah, next would be premiered. I'll premiere it because I'll be in Odisha next one. But I'll be in the live chat box. You can ask your doubts, so we can still chat. There is nothing big issue. কটক আসলে দেখা হওয়া কিছু কথা নেই. Why potassium is used in digoxin toxicity? See, potassium. Why potassium is used in digoxin toxicity? The reason being there is a pump called as sodium potassium adipase pump, and this pump is blocked by digoxin, and this pump is protected by potassium. Potassium, it hugs this pump and protects from digoxin. That is why I can use it. Kunj Dhabuwala, class 1C is most arrhythmogenic, but QT intervals remains normal. Yes, you are correct. That's correct. You're correct. That's correct. All right, guys. So that's all for today's live session, right? It's going to be 11 o'clock. So please work hard. Please work hard. Please work hard. And every day, don't forget, read, revise, re-revise. Third day, 5 minutes. Don't forget to overlook, right? Read well, because many students, they ask me, sir, I'm not able to revise in 15 minutes. If you're not able to revise in 15 minutes, that means on the first day, you have not read it well. So read well, invest time in the first day so that you can revise in 15 minutes, re-revise in 5 minutes. Please do that, please, please, please. If you don't do this, this is not going to help you. This will help you only if you do this. Yet last year, there are a lot of toppers who have done this and they've got rid of pharma. Pharma is difficult for a lot of students. It was difficult even for me. This is what I did. I did this when I was preparing for pharma and micro, two things which are difficult for me. Right. Second, I've told you to write down the drug of choice separately. So while you are covering every day, write down the drug of choice separately drug of choice. And before going to sleep every day, do revise 5 drugs of choice. How much time do you need to just go through 5 drugs of choice? Not even 5 minutes, maybe 1 to 2 minutes. 5 drugs of choice. Go through them, close your copy, go to sleep. Next day, read another 5 drugs of choice and try to actively recall if you remember the previous day's drugs of choice or not. So keep doing this every day so that you remember the drugs of choice on your tips. Half of pharma is done by that. So guys, that's all. Thanks a lot for coming to today's session, and I hope these sessions are helping you guys. And keep revising, reading. I'll try to conduct the live sessions whenever possible. Whenever it's not possible because of something, some commitment, some classes, I'll do a premiere session, and by that we will keep on moving forward. So don't give up and keep moving ahead, guys. Lots of love and blessings to all of you. This was Dr. Ranjan. Take care. Bye-bye.